of the critical care physician. So today I'm going to discuss something on pathophysiology of acute kidney injury secondary to COVID-19. First, I'll just give some brief idea about the general pathophysiology of this novel coronavirus. Then we'll narrow down the discussion to pathophysiology into acute kidney injury, how it's going to affect it. So before December 2019, there was no idea about this so-called COVID-19 viral pathology. So we had some idea about two pandemics, that is MERS-CoV and SARS-CoV, which happened previously. But this COVID-19, how it is going to spread, no idea. Its symptomatology, pathophysiology, therapeutic option, no idea at all. So currently we understood this COVID-19 can spread in all the three modalities, including contact, droplet, and airborne mode of spread. The worry is because of its speed and rapidity of transmission from person to person than its severity of the manifestation. So when it comes to pathophysiology, so the host response to coronavirus can involve monocyte macrophages, complement pathway, T and B cells. So B cells involvement helps in generating antibodies, that is IgG and IgM, after a week of onset of infection. T cell activation will lead to production of cytokines from WBC cells, which are interleukin 1, 6, and TNS alpha. These are the pro inflammatory cytokines that we call it as cytokine storm or cytokine reaction syndrome. It also involves complement pathway in its pathophysiology. When you see the host response to this COVID-19, the entire thing can be divided into viral response phase and host inflammatory response phase. So in the initial first stage, so that we call it as early infection, so most of the time patients will have some sort of prodromes like myalgia, headache, dry cough, and fever. Later, when they move to a frank pulmonary phase, they can have acute onset of breathing difficulty. They can manifest with hypoxia, with a low oxygen saturation, with a low PF ratio. When it moves to frank hyperinflammation stage, then they will have a well established ARDS, sepsis, secondary infection, shock, or other organ involvement. So it is basically so same spectrum with a different severity, different phases, clinical signs and biochemically also, which manifest in different way. So initially there will be increased prothrombin time, lymphopenia, elevated D dimer, LDH level. So next, when the severity is bit increased, so we'll get some abnormal chest imaging with a normal or low procalcitonin value, which is more specific for bacterial infection. Patient can manifest with some sort of transaminitis picture. So when the patient is going to have a hyperinflammation phase, then our acute phase reactants like C-reactive protein, D-dimer, ferritin will further elevate, and some patients will also have some atypical manifestation like myocarditis. They can have elevated troponin and N-terminal pro-BNP. So major thing during this phase is going to happen is so cytokine storm in terms of interleukin 1, 6, and TNF alpha. So based on the phase of pathophysiology, lots of therapeutic interventions has been tried, but we have to wait for lots of ongoing experimental results to come in near future. So this is overall early and severe stage. If you taken the primary organ which is going to have some hit, preliminary is the lung. So in the initial stage there will be intact of capillary membrane. So in the severe stage there will be surge of monocyte neutrophils. So there will be formation of hyaline membrane, like a frank ARDS, there will be leaky capillaries which leads to interstitial edema. So based on this, there has been therapies tried to cut all these pathophysiology in stage specific way. So next, there was some interesting theory behind this novel coronavirus, that is COVID-19 and angiotensin converting enzyme 2. If you understand the basic structure of the virus, which is going to have some proteins called spike proteins, so these are going to get activated by something called transmembrane protease serine 2 enzyme. So that's why initially protease inhibitors which we used for HIV therapy has been used like lopinavir and ritonavir, but none of the therapy has showed any benefit. When this spike protein get activated, which interact with angiotensin converting enzyme 2, so the basic function of this ACE2 helps in anti-entropy of the cells, anti-fibrotic action, anti-inflammation, antioxidant, and it also helps in vasodilation. In hypertensive patients, this ACE2 enzyme is going to get down regulated, so that's why there will be a lack of vasodilation in them. So when this virus is going to attack in hypertensive patient, further there will be decrease in ACE2 receptor and its physiological function, which leads to pro-atrophy, pro-fibrosis, pro-inflammation, increased lipid peroxidation and oxidation, and profound vasoconstriction. So lots of therapies has been tried to target each stage of this pathophysiology of COVID-19. So where other this angiotensin converting enzyme 2 is going to be expressed other than the lungs is it is in the heart. So that there are lots of case reports, case series which published from Italy. So they manifest with some sort of cardiomyopathy, myocarditis, pericarditis, some thrombotic events because of the expression of this ACE2. So other than that, so it's going to express on vascular endothelium, so intestinal epithelium. So interestingly, so COVID-19 can present as acute gastroenteritis in about 10 to 12% of the patient. So it will manifest with diarrhea, pain, abdomen, and vomiting. So it can manifest with thrombotic event like acute pulmonary embolism, hemoptysis, deep venous thrombosis. So basically, this COVID-19 will lead to procoagulant status also because of its action through the ACE2 receptor on vascular endothelium. So next, the organ which is going to involve is kidney because of its expression of ACE2 receptor. So initially, the data suggested the renal involvement was not so high in COVID-19, but later many of the data which I am going to discuss in further slides showed that kidneys are also going to suffer in COVID-19 infection. So this is going to happen overall because of this so-called cytokine storm. The patient is going to have immunocompetent young healthy individual. It can get recovered, or the storm can progress leads to multiple organ involvement. If you support the organ adequately, there is a possibility they will recover, or it may lead to poor outcome in terms of mortality. So in the same time, the patient get affected again to the origin of this so-called cytokine storm. This vicious cycle is going to continue further, leads to more and more multi-organ damage. So overall, it can manifest with cardiac involvement in terms of myocarditis. If you remember, so near about 12 to 13% of the patient can manifest with arrhythmia and palpitation. So gut manifestation I already explained. So liver in terms of transaminitis it can manifest, and finally kidneys are also one of the fate for this COVID-19 viral infection. So then recently we got one new proposed theory that the link of this COVID-19 to one beta chain of hemoglobin. If you see, hemoglobin is going to have four heme molecules. So each heme is going to have one porphyrin with the iron in the Fe2 nature. So this is the one which helps in carrying the oxygen to the cells, when this COVID-19 is going to attach to this one beta chain of hemoglobin, so then Fe2 is going to be released into the circulation and it become Fe plus 3, so then which causes like lipid peroxidation of membrane lipids, which leads to like oxidative stress free radical injury. That is also true for pathophysiology of acute kidney injury. But after this, no much data. We have to wait and watch for more and more in-depth knowledge in terms of COVID-19 related to this hemoglobin interaction. So, like if you see the overall data on the organ specific complication, so 80% of the patients with COVID-19 doesn't require hospital admission, but among the remaining 20% who required hospitalization, near about 4 to 5% require ICU admission. So among them, like near about 30% will have moderate to severe ARDS. So 15% will have viremia. So acute kidney injury incidence has been variedly described from about 4% to 15%. So cardiac injury, I told in terms of myocarditis and arrhythmia, so which can happen in about 12% of patients, and other secondary infection, particularly gram negative bacterial infection, can happen somewhere between 8 to 10%. So this is the organ support required. So respiratory, so advanced support in terms of mechanical ventilation was more as compared to cardiac advanced support requirement. Renal, we have to wait and watch for more and more data on this corner. So average duration of median duration of organ support, which may vary between 3 to 5 days, which includes both the basic and advanced requirement of the support. So when we narrow down pathophysiology of acute kidney injury secondary to this COVID-19, so if you see, before going to like proper pathophysiology, I already told incidence of this acute kidney injury varied from about 4 to 5% to maximum of 15 to 20%. The lowest was reported from China initially, that's about 0.5%. But as compared to the acute kidney injury, in general ARDS patient, which about 65% of the patients suffered, but in COVID-19 it is not so high, but still we have to wait for more and more in-depth data. So the exact incidence basically of this AKI is not known because of variable testing rates. The denominator is uncertain. So somewhere we can have some number maybe in and around 15% of this AKI incidence secondary to COVID-19. So when it comes to pathophysiology, so I already explained, so cytokine induced damage, that is the cytokine storm, is the major thing which is going to have an impact on multi-organ dysfunction. That is true in kidney injury also. When we have pro-inflammatory cytokine release, they act on peripheral vasculature, which creates peripheral vasodilatation, leaky capillaries. So because of that, they have hypotension. So renal perfusion pressure is going to be decreased because of interstitial edema, because of the leaky capillaries. So there will be intramedullary compartment syndrome will happen in the renal tissue. So again, this cytokine release can happen secondary to extracorporeal circulation like ECMO if the patient is on CRRT, or like invasive mechanical ventilation, which leads to biotrauma, that leads to release of this cytokine. So there are some like initial thought process. This COVID-19 can manifest as macrophage activation syndrome, that is hemophago lymphohistiocytic syndrome with bicytopenia and high triglyceride, high ferritin, high LDH value and all, which leads to cytokine storm. Again, so directly this cytokine will have an impact on the acute kidney injury. So other proposed theory is organ crosstalk. So we know that so heart can involve so directly because of the cytokine surge, or it may be because of secondary to viral myocarditis, which leads to cardiorenal syndrome. Whenever there is a cardiomyopathy with a poor contractility, so there will be back pressure, and this leads to renal venous hypertension. So renal venous congestion will happen. At the same time, because of the poor cardiac output, again it lead to decreased perfusion of the renal tissue. So other axis we need to understand is pulmonary and renal axis. Because of the alveolar damage leads to again some sort of cytokine storm. Along with that, patient if they had severe manifestation as ARDS with a poor oxygenation, so renal medullary hypoxia is also going to happen. So again, because of the peak airway pressure, increased intra-abdominal pressure leads to renal compartment syndrome, which compromise the renal perfusion. So one more theory which proposed many patients with this COVID-19 presented with skeletal muscle injury with a rise in CPK value. That is because of this rhabdomyolysis, which causes tubular toxicity also. So one more important part of this pathophysiology is systemic effect. It may be aggressive initial fluid balance, which leads to accumulated positive fluid balance with breach in endothelium of this glycocalyx, and it can also lead to renal compartment syndrome, which decreases the renal perfusion. So on the other hand, as I already told, endothelial damage will lead to third spacing and decreased effective intravascular volume to perfuse the kidneys. So again, secondary bacterial infection leads to lipopolysaccharide, that the endotoxin, because of the gram-negative sepsis that leads to septic AKI. So multifactorial, multiple pathophysiological pathways has been linked to this acute kidney injury secondary to COVID-19. But interestingly, the initial data which we got from China, that is Wuhan city, what they have done, so post-mortem, they have seen like a case series near about 9 out of 26 autopsied COVID-19 patients in China experienced this acute kidney injury. So primarily, the characteristics on light microscopy, they have diffuse proximal tubular injury with some areas of frank necrosis. Again, some more data. This is a bit larger data, again, which suggested, so among these 85 patients, they have done some retrospective analysis of estimated GFR. So in between January to March in Wuhan of this initial coronavirus infection, so near about 27% of the patient had this acute kidney injury. This is a bit higher incidence as per the literature. So elderly patient with multiple comorbidities like hypertension, heart failure had more of this developed this acute kidney injury. Post-mortem, interestingly, they had severe acute tubular necrosis, lymphocyte infiltration, antigen infiltration, macrophage infiltration in the tubulointerstitial tissue, and along with complement deposition. So lots of theories, lots of whatever pathophysiology has been explained in general that also suits for pathophysiology in AKI in COVID-19 related infection. So other interesting two articles which proposed and which came up with some findings are like they have proteinuria significantly near about 40 to 60%, also hematuria in about 25% in one of the largest study among near about 700 patients. So this also interestingly showing that some significant renal injury is going to happen in COVID-19 patients. Again, interestingly, I just searched is this COVID-19 passes in urine. So initially, only one patient they reported on the seventh day. So they saw presence of like COVID-19 virus in the urine, but after that, they have done near about 72 urine analysis. None of the patient had any of the presence of the virus in the urine. So this is something we need to understand. Those who already having a baseline elevated creatinine, the accumulated mortality was also significantly very high as compared to those patients who doesn't have any baseline existing renal dysfunction. If you see, if the patient had AKI after the COVID-19 infection, it's not like baseline they are having any renal dysfunction. Is this going to have some impact on the mortality? Definitely, because when there is increase in stage of renal dysfunction from stage 1 to stage 3, so there is an increase in hazard risk ratio from a factor of 1.7, so it doubles the mortality, no doubt on that. So longer the duration of acute kidney injury, worse longer the outcome in terms of cardiovascular system, there is a high chance they can lead to chronic kidney disease. So this is again the same thing. If the proteinuria moved from 1 plus to 2 plus 3 plus, so hazard risk is also increasing. Hematuria, it also the same way. If it increase in severity, increase in the hazard risk ratio of the mortality. When the stage of renal dysfunction moved from stage 1 to stage 3, again it increases the mortality and poor outcome. So overall, so COVID-19, the incidence of AKI which varies from 0.5 to 30%. On an average, it's about 10 to 15%. So they need some sort of renal replacement therapy in a continuous modality. So more common in ICU settings. So they have in add-on to this rise in creatinine, they manifest with proteinuria, hematuria, that is particularly albuminuria in about 30 to 60% of the patient. So more common in patients with the existing cardiovascular disease, chronic kidney disease, diabetic and hypertensive patients. So when it comes to like what to understand, so it is a struggle between pro-inflammatory and that of the anti-inflammatory cytokines and the host response to this COVID-19. So if you have not supported them with the basic pathophysiology, so we are not able to maintain the homeostasis and we are not able to flatten the curve, which may move more towards pro-inflammatory response. So currently, as long as we don't have any specific proven therapy or vaccine, so the like we have to continue supportive care. So it's a continuous phase of understanding and learning the pathophysiology. So till that time, we have to target the pathophysiology, like so target the cytokines, some immunomodulation, antioxidant, anti-inflammatory therapy, but we have to watch for more and more evidence continuously. So with this, I'll just conclude. So how COVID-19 can lead to acute kidney injury, what basic pathophysiology also is going to have an impact when it comes to renal dysfunction in relation to COVID-19. Thank you all.